Welcome to Care of Patients with Esophageal Problems. GERD, or gastroesophageal reflux disease, is the most common upper GI disorder in the United States. It occurs most often in middle and older adults, but may occur at any age. So what actually occurs with reflux of GI, what actually occurs is there is a reflux of GI contents into the esophagus. It backs up, so to speak. The exposure of esophageal mucosa to the acidic gastric or duodenal content then in return causes inflammation. Now, this is normally prevented by the presence of the upper esophageal sphincter and the lower esophageal sphincter. The most common cause of GERD is the relaxation of the lower esophageal sphincter. Individuals who are overweight or obese are at greatest risk for the development of GERD related to increased weight, and that increased weight increases their intra-abdominal pressure, which contributes to the reflux of GI contents into the esophagus. Nighttime reflux does cause prolonged exposure of the esophagus to acid because individuals are in a supine position, and there is decreased peristalsis and the benefit of gravity. So let's talk about a little bit of the clinical manifestations of GERD. An individual suffering from GERD may be asymptomatic. The reflux material is returned to the stomach by gravity, saliva, or peristalsis. The healthy esophagus displaces or removes reflux contents quickly. However, if an individual has an inflamed esophagus, it does not. Therefore, the length of exposure increases with the number of episodes. As a result of the inflammation in the esophagus, hyperemia and ulceration can occur. Now, the body does attempt to heal the inflamed areas of the esophagus by producing new tissue that is more resistant to the acid, and that is called Barrett's epithelium. So this tissue is considered pre-malignant and is associated with an increased risk for cancer with prolonged GERD. Aside from the Barrett's epithelium, fibrosis and scarring does accompany the healing process, and it will lead to esophageal strictures, which is a narrowing of the esophagus. And this progressively causes the individual to have some difficulty swallowing or dysphagia. Other clinical manifestations include the water rash, the belching, flatulence. Individuals with GERD may have a chronic cough. There may be some wheezing. There's some atypical chest pain. They may also have vomiting, bloating after eating, as well as some nausea and vomiting. Now, uncontrolled esophageal reflux does lead to other conditions such as asthma, laryngitis. Individuals can have cardiac disease, dental decay. There's a table 54.1 in your textbook that identifies factors that contribute to reduced lower esophageal sphincter pressure. So with that, please note caffeine, chocolate, tomatoes, and tomato-based products. Citrus fruits, smoking, alcohol, NG tube placement. These are all contributing factors. So when you think about nutritional interventions, what would you teach your patients to avoid or discontinue the use of if they are experiencing acid reflux? Dyspepsia, I also want to mention that it is also recognized as indigestion. These individuals may also have feelings of uncomfortable fullness because many don't review indigestion as a serious concern. Many will have a delay in seeking treatment. So I also want to mention that the symptoms or manifestations of GERD also worsen when an individual bends over, they strain, or they lie down. With severe indigestion, the pain may radiate to the neck or jaw and may be referred or refined to, I should say, the to the back. And that talks about the trying to think of a way to put this. That referred pain being that the problem is in one location, but you will feel it somewhere else. You talked about that in your pain modalities lecture in Foundations. For instance, a person may be having a myocardial infarction. They're having a heart attack, but they may feel nauseous, or they may have pain in their left arm or in their jaw. It's not exactly where the problem is, but it's that referred pain related to that problem. A lot of times with GERD, depending on the severity of it, patients can also present to the ED thinking that they are having a heart attack. Non-pharmacological interventions. There is no definitive diagnostic test for acid reflux. Healthcare providers may order a barium swallow, upper endoscopies, or EGD, or they may do pH monitoring examinations to identify structural or anatomical abnormalities associated with inflammation. They may look to see if there are any fibrosis or scarring related to GERD. For the most, GERD can be controlled by nutrition therapy, lifestyle changes, and drug therapy. Non-surgical management is to relieve the symptoms, to treat the esophagitis, and to prevent any complications such as strictures or Barrett's esophagus. GERD is a chronic disease that does require ongoing management, and it should be treated aggressively in older adults. And there is a area in your textbook on page, let's see, (11, 12) that talks about special considerations for older adults who are diagnosed as having GERD. Older adults are at risk for developing severe complications associated with GERD due to age-related physiological changes, medication side effects, and an increased prevalence of hiatal hernias. Instead of heartburn associated with GERD, this population experiences more severe complications such as atypical chest pain, ear, nose, and throat infections, and pulmonary problems such as aspiration pneumonia, sleep apnea, and asthma. Barrett's esophagus and esophageal erosions are also more common in the older adult. Nutrition therapy is useful with relatively mild GERD. Inquire regarding the patient's basic meal patterns and their food preferences. Teach the patient to avoid or limit foods that decrease lower esophageal sphincter pressure and initiate inflamed tissues such as peppermint, chocolate, alcohol, fatty, especially those foods that are fried, caffeine, carbonated beverages. The individual should also avoid spicy and acidic food, no orange juice, no tomatoes, especially while the tissues are inflamed. Smoking and alcohol cessation are also important. Other nutritional interventions would include educating the patient to eat 4 to 6 small meals per day rather than 3 large meals. Patients must also be educated to avoid eating at least 3 hours. Let me say that again. Patients should be educated to avoid eating like right before they are about to retire for the evening. They should be educated to eat at least 3 hours before bedtime. There's a chart in your textbook 54-2 that focuses on patient and family education, preparing for self-management, health promotion, and lifestyle changes to control reflux. It would be a good idea to look over that chart in your textbook. Again, that's chart 54-2. Elevation of the head of bed by 6 to 12 inches, whether with cylinder blocks or a wedge pillow. is instrumental in reducing GERD. Sleeping on the right side to facilitate frequent swallowing and to promote oxygenation to clear the esophagus. Losing weight, because you lose weight, then it decreases the intra-abdominal pressure, avoiding any binding or tight-fitting clothing, avoiding any lifting of heavy items, any straining, working in a bent over position. Anything that would decrease the intra-abdominal pressure would also alleviate the symptoms. Drug therapy for GERD includes antacids, H2 blockers, and protein pump inhibitors. So antacids elevate the pH level of the gastric contents, thereby deactivating the pepsin. The H2 blockers, they decrease the gastric acid production, and the PPIs provide effective long-acting inhibition of gastric acid secretion. Now, the antacids are useful with occasional dyspepsia, but not with frequent symptoms. Antacids that contain aluminum hydroxide or magnesium hydroxide may be used. Maalox and Mylanta are those most often utilized. Antacids should be taken 1 hour before or 2 to 3 hours after each meal. Gaviscon is another antacid that is used that forms a thick foam to cover the gastric content and to coat the esophagus and serve as a buffer with reflux activity. Gaviscon should be taken with food. H2 blockers, these are your famotidine, traded as Pepcid, or ranitidine, which is traded as Zantac, and these, again, decrease the gastric acid production. PPIs, omeprazole, which is Prilosec, pantoprazole, which is Protonix, esomeprazole, which is Nexium. These are names of the main treatment drugs, or PPIs, I should say, for severe GERD. Basically, you have to look at it as a step approach. We start out with encouraging patients to take antacids. That doesn't treat it. Remember, antacids are not good for frequent symptoms or severe GERD. Antacid doesn't work, then we place you on an H2 blocker. If the H2 blocker does not work, then we place you on a protein pump inhibitor. Protein pump inhibitors are the main treatment, again, for severe GERD. They do provide effective long-acting inhibition of gastric acid secretion. For patients who are in PO, you may have even seen Protonix or Nexium administered intravenously, especially in our acute care settings in which we're doing clinical at this time. And a lot of times this is done by prophylactic means, as these individuals are in distress at this moment. Because of that distress, they have an increased risk of stress ulcerations, so they will be provided with medication that inhibits gastric acid secretions to cut down on the likelihood of those stress ulcers being formed. So when you think about surgery for GERD, you have the endoscopic strata procedure, which is preferred. It's during this procedure that the ND applies radiofrequency energy through the endoscope using needles placed at the gastroesophageal junction. This energy decreases the vagal nerve activity, and it reduces the discomfort for the patient. Post-operatively, these individuals will remain on clear liquids for 24 hours after the procedure, and after the first day the diet is advanced as tolerated to full clear soft diet, and advance more so until the individual is able to resume their prior diet. Patients are educated to avoid NSAIDs for 10 days and to continue their drug therapy, usually a PPI, as if it has required surgery, then that individual had to have severe GERD. They are encouraged to use liquid medications and to avoid NG placement in their treatment or educating their providers on this surgical procedure as well, so that they avoid NG placement for at least 1 month, and that's related to risk for or risk of esophageal perforation. These individuals should also be educated to contact their healthcare providers if they have any chest or abdominal pain, any bleeding, any dysphagia, shortness of breath, or numbness, or nausea and vomiting. These interventions are also listed in chart 54.3 of your textbook. A small percentage of GERD patients will require surgery. There is also the Nissen fundoplication. It may be done laparoscopically or open traditional approach. The surgeon actually wraps a portion of the stomach fundus around the distal esophagus to anchor it and reinforce the lower esophageal sphincter. So, hiatal hernia, we talked about this a little bit in your non-inflammatory bowel disorders. So, you know that hernia is a protrusion of the stomach. Hiatal hernia is a protrusion of the stomach through the esophageal hiatus of the diaphragm. It's also called a diaphragmatic hernia. Most common is a sliding hernia. And this next slide is pictorial of the different types of hiatal hernias. You have the normal, you have a sliding hiatal hernia. Remember, that is the most common. And then you have the rolling hiatal hernia. Clinical manifestations of hiatal hernias include heartburn or indigestions, regurgitation, pain. They may have that difficulty swallowing, belching, and they have a worsening of symptoms after eating or when they are in a recumbent or lying position. Non-surgical management. What do we do for those hiatal hernias? Antacid and PPIs. Think about the action of those drugs that we just went over. Nutrition therapy. Think about, what are we doing for GERD? Same nutritional therapy would apply. Look at the treatment, antacids and protein pump inhibitors. It's the same thing that we are doing for GERD. Same lifestyle changes as well. Surgical management, perioperative or preoperative, includes lab work, patient teaching, same as all surgeries. Intraoperative, the procedures. Well, there is a procedure to reinforce the lower esophageal sphincter. There's the Nissen fundoplication. There's also the paraesophageal repair. Postoperatively, there is that risk for bleeding and infection, although not common. Postoperative nursing responsibilities would include observing for any complications and patient teaching as well. Let's see, something else I wanted to tell you all. There's a nursing safety priority on page 1115 that offers important information such as the elevation of the head of bed. It reinforces what I said earlier about the avoidance of restrictive clothing as well as weight reduction. So make sure you all review that to kind of reinforce that information. Surgery may be required when the risk for complications are high or there is severe damage with any reflux, whether it's GERD or whether it's caused by a hiatal hernia. All procedures have the goal of reinforcing that lower esophageal sphincter. Again, that Nissen fundoplication is the most common operative procedure. The paraesophageal repair is also an option. And when they do this, they make several half-inch incisions in the abdomen to allow access to the hernia, to close it, and then they reinforce the area with a mesh. This procedure can be done as a minimally invasive surgery as well as an open approach. But again, our gold standard is to always perform procedure laparoscopically. And we talked about bleeding and infection. Nursing care priorities that focus on observing for complications and providing health teaching. You have a chart in your textbook 54.5 in which it outlines that for you as well. Let's see. And that's what the niacin fundoplication or the paraesophageal repair. It talks more about the diet, how these individuals will need to remain on those anti-reflux drugs. Walking is good exercise for them, but they don't need to do any heavy lifting. It talks about providing the incision care, reporting any fever, and ensure that these individuals do follow up for appointments post-operatively. With the prioritization of care, the prevention of respiratory complications are also a concern. Remember, take into consideration your ABCs. Remember back to your perioperative lecture. And as listed in an action alert on page 1116, the primary focus of care after conventional surgery for hiatal hernia is the prevention of respiratory complications, elevating the individual's head of bed at least 30 degrees to lower the diaphragm and promote lung expansion, assist them out of the bed to begin ambulating as soon as possible. Being sure that these individuals support their incision during coughing to reduce pain and to prevent any excessive strain on the suture line, especially with more obese patients. Remember, with obese patients, there are those instances in which sometimes you have to use the abdominal binder. And because of this and that strain on the incision, sometimes you have those individuals that are heavier that need this surgery, and those individuals are encouraged to lose weight prior to the procedure. Now, there is a small percentage of those ineligible for the laparoscopic niacin fundoplication who require an open or traditional procedure. These patients will receive education on chest tubes as well as the NG tube that will be inserted during surgery. And note that NG tube will remain a few days afterwards. Oral intake, again, is gradual after the return of peristalsis. The incision is high, which makes deep breathing extremely painful. So splinting and pain control is imperative. I'd also like to point out that post-operative care with that nasogastric tube management, it should be checked every 4 to 8 hours for replacement, and it should be properly anchored to prevent any displacement, as reinsertion could perforate the fundoplication. It is important to ensure placement and patency to keep the stomach decompressed, as retching and vomiting could cause strain and could lead to rupturing the stomach sutures. This drainage will be initially dark brown and old blood, but it will become more of a normal yellowish green within the first 8 hours after surgery in the canister for that nasogastric tube. Nutritional care, again, clear liquids, and then we advance that diet as tolerated. Dysphagia is coming at the first feed, so individuals do have to be monitored closely to prevent aspiration pneumonia. There are some surgeons that also may place a temporary gastrostomy for feeding, and that will allow undisturbed healing of the repair. The food storage area is reduced with this surgery, so meals should be small and frequent. Post-op complications. These post-op complications are also listed in chart 54-6 of your textbook. However, I would like to specifically address the gas bloat syndrome and the aerophagia as they are common. In gas bloat syndrome, the individual is unable to voluntarily belch. It is temporary and it may persist. It is found in the MIS as well as the open approaches to surgery. Education is key, as patients should be taught to avoid carbonated beverages, to avoid the utilization of straws, chewing gums, gas-producing foods, especially those with high fat. Aerophagia is air swallowing from an attempt to reverse or clear acid reflux. Individuals should be educated to relax consciously before and after meals, to eat and drink slowly, and to chew their food thoroughly. Air does become trapped in the stomach, and that can cause extreme discomfort. Patients should be encouraged to ambulate frequently as well as change positions to eliminate air as well. Simethicone use is also encouraged to help aid the patient, in ridding themselves of trapped air. Surgery does control the condition. A cure is rare, and lifestyle modification should be lifelong. Esophageal tumors. So esophageal tumors may be benign or malignant. However, most are malignant. Esophageal tumors grow rapidly as there is no serosal layer to limit their extension. The esophageal mucosa is richly supplied with lymph tissue, so there is early spread to the lymph nodes. Cancers of the esophagus, you can look at these as silent tumors in their early stages with few observable signs. And then by the time the tumor does cause symptoms, it is by that time extensively spread. Primary risk factors associated with esophageal tumors are smoking and obesity, with obesity having a 16-fold increase. Other risk factors include malnutrition, untreated GERD, excessive alcohol intake, as well as foods that are high in nitrosamines, such as pickled and or fermented foods. Changes in the cellular structure of the esophagus as a result of exposure to acid and pepsin found with GERD, when those individuals have that Barrett's epithelium or Barrett's esophagus, this dysplasia does ultimately become malignant. Remember, it's pre-malignant when it actually forms. Excuse me. History risk factors include gender, alcohol and tobacco use, dysphagia or reflux, and weight loss. Chart 54-7 identifies key features or manifestations of disease such as dysphagia, adenophagia, which is painful swallowing, halitosis. These individuals will have chronic hiccups, a chronic cough, and rapid weight loss. They'll have a weight loss of more than 20 pounds, as well as experience changes in their bowel habits. The diagnosis of esophageal tumors is made via a barium swallow. A definitive diagnosis is made via an esophageal ultrasound. An EGD may also be performed to inspect the esophagus and obtain biopsies of tissue specimens for cell studies and disease staging. The positron emission tomography, also known as the PET scan, is useful in identifying metastatic disease, which is more accurate than a CT scan. The most specific or common problem with esophageal cancer is decreased nutrition intake related to impaired swallowing and possible metastasis. The goal is to maintain or improve nutritional status. Non-surgical interventions include nutrition therapy, swallowing therapy, and chemotherapy and radiation. Nutrition therapy includes semi-soft and thickened liquids as they are easier to swallow. Liquid nutrition supplements such as Ensure or Boost are also used to help to provide supplemental nutrition. They are used between feedings, and that's the increase in the caloric intake. Enteral or two feedings may be needed temporarily when the dysphagia is severe. In those with complete esophageal obstruction or life-threatening fistulas, the surgeon may create a gastrostomy or jejunostomy for feeding. Daily weights are important, as well as keeping the head of bed elevated to prevent any reflux. Speech language pathologists are a great asset to dealing with individuals who are suffering from esophageal cancers. They're there to assist with oral exercises to improve swallowing. Patients are taught a number of different exercises to help with swallowing, such as the chin tuck, for example. Dysphagia and adenophagia are major concerns. I think airway, this is a priority. When the individual with an esophageal tumor is eating or drinking, they should be monitored for signs and symptoms of aspiration, such as choking or coughing. You'll notice that when you're doing your reading that in late disease, even saliva may cause choking. Food aspiration can cause airway obstruction, pneumonia, or both, especially in the older adult. So this is something patients and their families should be educated on. Chemotherapy used in treating esophageal cancer has proven to be only moderately effective. However, in combination with radiation therapy, the two are the best chance of a cure. Target therapies may be utilized in combination with radiation and chemotherapy. PDT or photodynamic therapy is used as palliative therapy in non-surgical candidates or in those with small localized tumors. This therapy uses performed sodium to collect cancer cells for destruction. Esophageal dilation is used to relieve dysphagia. Laser therapy or electrocoagulation via endoscopy may also be utilized for palliative measures when a cure is not readily available. Surgical management includes esophagectomy and esophagogastrostomy. Esophagectomy is the removal of all or part of the esophagus, and esophagogastrostomy involves the removal of part of the esophagus and the proximal stomach. Early stage cancer patients have a minimally invasive esophagectomy. However, most will require open or traditional surgeries, and that's due to the size of the tumor and if metastasis is present, because remember, this esophageal cancer is a silent disease that is extreme upon discovery most often. And I shouldn't say extreme, I should say extensive upon discovery. Conventional or open procedures are associated with many complications and death. Remember, our gold standard will always be MIS. Pre-operatively, patients should be advised to stop smoking I want to see it's 2 to 4 weeks before surgery, but hold on just 1 second. Let me confirm that. Yes, 2 to 4 weeks before surgery, and that's also listed in your textbook. Oral care preoperatively is important and emphasized to decrease the risk for infection postoperatively. If Individual has, if colon interposition, meaning resecting a piece of the colon and creating an esophagus, is planned, then that individual should have a complete bowel prep done before surgery as well. Post-operatively, the highest priority is the respiratory system. Patients should be kept in a semi to high Fowler's position with the chest tube placed. Nurses must monitor for changes in the volume and color of the drainage present. Cardiovascular complications, particularly hypotension during surgery, can occur as a result of pressure on the posterior aspect of the heart. Malnutrition or prior exposure to chemotherapy or radiation increases the susceptibility of a patient to infection. Serious risks are associated with leakage at the sites of anastomosis, especially with colon interpositions, due to tension, poor blood supply, and delayed healing. Wound management is a major postoperative concern due to multiple incisions and drains. Patients should be educated to support the incision during their turning and coughing to prevent any dehiscence. Remember, obese individuals should have an abdominal binder. You can use a pillow, a teddy bear. They need something just to splint their incision. If an anastomosis leak were to occur, all fluid intake is discontinued and it is not resumed until the site of the leak has healed. The leakage is evidenced by an occurrence of fever, fluid accumulation, and manifestation of early shock, such as increased respirations, altered mental status, increased heart rate. These signs should be reported immediately, as if they progress to becoming fully septic, then that can be detrimental up to and including death. An NG tube is placed intraoperatively for these surgeries to decompress the stomach to prevent tension on the suture line. While it is our responsibility to monitor for patency and to ensure that the tube is anchored appropriately to prevent dislodgement, you will not irrigate or reposition this NG tube unless that request is made by the surgeon. The initial drainage in the NG tube will be bloody, but again, it changes to greenish yellow by the end of the first postoperative day. The continued presence of blood may indicate some internal bleeding at the suture line. And just in case you need to reinforce those concepts regarding NG tube care, there is some information regarding best practice with NG tube related to these specific surgeries in your textbook, chart 54-8. Post-operatively, initial feedings begin through the jejunostomy or the J tube. The feedings are slowly increased over the next several days and discontinued once the patient has taken in adequate oral nutrition. You will not aspirate for residual with these feedings, and that's due to the increased risk of the mucosal tearing. Before oral nutrition is initiated, a esophagram study is completed to detect to see if there are any leaks at those sites of anastomosis. If there are any structures or any signs of aspiration, then it would pick up on that as well. And if non-present, then you have the liquid diet started, and then once we start the clear liquids, full liquids, soft, and you're basically just advancing your diet as tolerated. See, is there anything else I want to say about? Patients are educated to eat 6 to 8 small meals per day with fluids in between, but not with the meals, and that's to decrease the incidence of diarrhea. Esophageal diverticuli. Diverticula are sacs resulting from the herniation of esophageal mucosa and submucosa into surrounding tissue. The most common form is Zinker's diverticula, which occurs most often in older adults. These individuals will report some dysphagia, regurgitation, and a nocturnal cough and halitosis. Those diagnosed with esophageal diverticula are also at an increased risk for perforation. A diagnosis is made via an EGD that is performed with strict care due to the risk for perforation. Nutrition therapy and positioning are major interventions for controlling symptoms. Semi-soft foods, smaller meals are often best tolerated and may reduce or relieve symptoms of pressure and reflux. Patients should be educated to sleep with the head of bed elevated to avoid being in a supine position. Or I should say a flat supine position. Patients should also ensure that they have eaten at least 2 hours prior to laying down for bed. Surgical management is aimed at removing the diverticula. Post-operatively, the patient is NPO for several days to promote healing. They do receive IV hydration and tube feedings with progression to oral fluids and food. NG tubes are placed to decompress the stomach. They are not irrigated or repositioned again unless requested by the surgeon. Pain relief measures and monitoring for complications such as bleeding and perforations or priorities of care as well. Esophageal trauma. This is trauma to the esophagus. It can be as a result of blunt injuries, chemical burn, surgery, or endoscopy, which is rare. It can also be from the stress of continuous or severe vomiting. Patients with esophageal trauma are initially evaluated and treated in the ED. Assessment does focus on the nature of the injury and circumstances surrounding it. ABCs are important here. They are a priority of care, assessing for airway patency, breathing, chest pain, and dysphagia, vomiting, bleeding, and all priorities of care. Non-surgical management includes esophageal rest for more than 1 week after the injury to allow for initial healing of the mucosa. The patient is kept NPO to prevent further leakage of esophageal secretions. Esophageal and gastric suction facilitates drainage, and it does allow the esophagus to rest. TPN is utilized to provide adequate caloric intake to prevent sepsis. Healthcare providers prescribe broad spectrum antibiotics. High-dose steroids are also ordered to suppress the inflammation and prevent strictures. Opioids are prescribed for pain control, and lidocaine may be utilized for mouth burns. Surgical management allows for the removal of damaged tissue. Severe injuries may require resection of a portion of the esophagus with a gastric pull-through and repositioning or replacement by a bowel segment. G-tubes may also be placed for nutritional needs as well. So let's move on to patients or care of patients with stomach disorders. Gastritis is the inflammation of gastric mucosa. Gastritis can be erosive or non-erosive. Acute gastritis typically heals before several months, but this is not the case with chronic gastritis. Acute gastritis is caused by the inflammation of the gastric mucosa or submucosa after exposure to local irritants or other causes. Symptoms of acute gastritis include mild to severe epigastric discomfort, anorexia, cramping. The individual may have abdominal tenderness, bloating, nausea, and vomiting. Chronic gastritis appears as a patchy, diffuse inflammation of the mucosal lining of the stomach, resulting in thinning and atrophy of the walls and the lining of the stomach. Chronic gastritis is associated with the increased risk for gastric cancers related to chronic inflammation. Type A is associated with the presence of antibodies to parietal cells and intrinsic factor, and it is most likely related to autoimmune disease. Type B is caused by H. pylori infection and is more common. Type B is also associated with long-term NSAID use. Pernicious anemia is associated with chronic gastritis. Type A, to be specific. The intolerance of fatty or spicy foods is associated with chronic gastritis as well. If that person presents with emesis, gastric hemorrhaging, or dyspepsia, these are all associated with acute gastritis and are considered, excuse me, a life-threatening emergency. Epigastric discomfort, anorexia, and nausea and vomiting are associated with both acute and chronic gastritis. Non-surgical management for gastritis includes primarily identifying and eliminating whatever that causal factor is. Acute gastritis is treated symptomatically and supportively because the healing process is spontaneous, usually occurring within a few days. When the cause is removed, pain and discomfort usually subside. Fluid replacement is imperative with severe fluid loss, as well as blood transfusions with severe blood loss. Treatment of chronic gastritis varies with cause. The approach to management includes the elimination of the causative agent, treatment of the underlying disease, such as Crohn's, avoidance of toxic substances, and health teaching. Pain relief is provided with drugs that block and buffer gastric acid secretions. This is also imperative in the care of the individual that has gastritis. So remember, that could be H2 blockers, antacids, PPIs, mucosal barrier fortifiers, anti-secretory agents. If that person has pernicious anemia, then we would need to supplement with vitamin B12. If that chronic gastritis is caused by H. pylori, of course, eliminating the H. pylori infection would be the primary treatment approach. H. pylori is treated with a PPI, most often lansoprazole, and 2 antibiotics for a course of 10 to 14 days. Healthcare providers may order the quadruple therapy and add bismuth to the regimen. The available antibiotics for treatment include metronidazole, tetracycline, clarithromycin, and amoxicillin. So make sure that you all are aware of the treatment for H. pylori. Remember, there can be a triple treatment in which they do the 2 antibiotics and a PPI, most often lansoprazole, or they can do the quadruple therapy, which will be the lansoprazole, the PPI, the 2 antibiotics, and they will add bismuth. And the available antibiotics that they can use for treatment include metronidazole, amoxicillin, clarithromycin, and tetracycline. And that's also listed in your PowerPoint for you. Other therapies, non-surgical therapies, I should say, would include limiting the intake of tea, coffee, cola, or carbonated beverages, chocolate, mustard, as well as the cessation of smoking cigarettes and drinking alcohol. Research has shown patients seem to progress better with bland, non-spicy diets, smaller, more frequent meals. Patients should be educated on various techniques to reduce stress and discomfort, such as progressive relaxation, guided imagery, and distraction, as included in the complementary and alternative therapies. Patients with gastritis should also be educated to avoid NSAIDs. Remember, NSAIDs can lead to GI bleeds. They should read all over-the-counter drug labels, as many contain aspirin and NSAIDs. So they want to avoid those aspirin and NSAIDs. Gastritis, and what are we going to do to treat the gastritis in regards to surgical management? Well, surgical management would include partial or subtotal gastrostomy, as well as a total gastrostomy. So what I am going to do, I am going to talk about those in detail, but I'm going to I'm trying not to make this redundant. Give me just a second. I'll go into full detail with the explanation of these when we talk about peptic ulcer disease under the surgical management, because you will also note as we progress with the PowerPoint that the subtotal gastrectomy is included in the management of PUD as well. Okay, so peptic ulcer disease. Peptic ulcer disease is or it results when mucosal deficiencies become impaired and no longer protect the epithelium from the effects of acid and pepsid. So a peptic ulcer is a mucosal lesion of the stomach or duodenum. There are actually three types of ulcers: gastric, duodenal, and stress ulcers. Most gastric and duodenal ulcers are caused by a H. pylori infection. Notice that H. pylori, even as you see in your reading, causes many GI-related issues. It is unclear how it is transmitted, but it is believed to be spread through contaminated food or water, or by fecal oral route, and acquired in childhood. So this is a pictorial that addresses the most common sites of peptic ulcer formation. This is also in your textbook. It's figure 55-2. Gastric ulcers usually develop in the antrum of the stomach near the acid-secreting mucosa. Duodenal ulcers occur in the upper portion of the duodenum. They are deep, they are sharply demarcated lesions that penetrate both the mucosa and the submucosa. The flora of the ulcer consists of a necrotic area, so take the time to review the pathophysiology of each ulcer. What else do I have? Gastric ulcers are deep and penetrating. They usually do occur in the lesser curvature of the stomach near the pylorus. Duodenal ulcers, there is normal diffusion of acid back into the stomach and the tissues, with an increased secretion of gastric acid and an increase in the stomach emptying. The main feature of duodenal ulcers is that there is high gastric acid secretions, as well as excess acid in the duodenum for a long period of time. And the rapid emptying of food reduces the buffering effect, so a large acid bolus is delivered to the duodenum. Stress ulcers are acute gastric mucosal lesions that occur after an acute medical crisis or trauma. A person who's NPO for surgery may have gastritis that may lead to stress ulcers, which are multiple shallow erosions of the stomach or occasionally the proximal duodenum. Little is known regarding stress ulcers and their exact etiology, but they are associated with lengthened hospital stays and increased mortality rates. Um, Remember, IV therapy with a PPI or an H2 blocker is seen in those acute hospitalized patients who are NPO. They may also have oral PPIs ordered, and this again is for prophylactic use. Bleeding is the main manifestation of acute stress ulcers. And when you take into consideration gastric ulcers, you have the acid, the pepsin. Remember, the H. pylori infection plays an important role in the development of ulcers in the stomach. Remember, the H. pylori is something that's acquired during the childhood. Um, Most gastric ulcers are found in the lesser curvature of the stomach. And I also provide a breakdown of the patho for you all, as well as definitive information as to how the ulcer results, and that is because there is a break in the protective mucosal barrier, and the hydrochloric acid injures the gastric epithelium. And this I've already went over. I got a little ahead of myself. PUD clinical manifestations. So physical assessment findings may include epigastric tenderness, dyspepsia or indigestion, which is most common. Complaints of indigestion are usually described by patients as sharp burning or a gnawing pain. Some may also report a sensation of abdominal fullness or hunger. Older adults may present with nausea and vomiting rather than abdominal discomfort. PUD, gastric versus duodenal or ulcers. So let's take a moment to recognize key differences in gastric and duodenal ulcers. We have discussed the patho, stomach acid production. So let's focus on the pain of each. Gastric ulcer pain often occurs in the upper epigastrium, and it localizes to the left of the midline. Gastric ulcers are aggravated by food, because when food comes, guess what else comes? Acid and the pepsin. Duodenal ulcers are associated with pain to the right or below the epigastrium. This pain occurs 1.5 to 3 hours after eating. It can also often wake the individual from their sleep. So think about where the pain is. Remember, gastric left with midline, aggravated with eating, upper epigastrium. Below the epigastrium, you see duodenal. This is the one that, remember, 1.5 to 3 hours after eating or during the night, it may wake them out of their sleep. Pain with duodenal ulcers may be exacerbated by certain foods such as tomatoes, fried foods, spices, alcohol, or caffeinated drinks. Bleeding that occurs at or above the duodenal jejunal junction is an upper GI bleed that presents as hematemesis, as fresh, bright red blood or old blood that would resemble coffee grounds. And With the melena, the digestion of blood within the duodenum and the small intestines may result in black stool. The dark tarry stool is called melena and is also a key feature of an upper GI bleed. And all of these key features are listed in chart 55.3. PUD and reducing pain. One of the expected outcomes for those diagnosed as having PUD is pain management. Interventions for pain management focus on drug therapy and dietary changes. Analgesics are not the mainstay for pain relief with PUD. You know, you're looking at what's going to fix the problem. Well, if I do something about the acid, that's going to fix the problem. So that's why your antacids, your H2 blockers, and your PPIs are the predominant or mainstream lines of treatment or therapy. H. pylori treatments are corrected, initiated as well. Consider that the pain is only present because of the pathophysiological changes, and if those are treated by, again, decreasing the acid production, then you have solved your problem. Drug therapy with PUD. Chart 55.4 in your textbook does list common examples of drug therapy. You will recall you saw many of these used with acid reflux. So the goal is to provide pain relief, heal the ulcerations, and prevent any recurrence. So these are just different drug classes that are used in the treatment of PUD. Hyposecretory drugs. These are drugs that cause a reduction in gastric acid secretions. Protein pump inhibitors. H2 receptor antagonists or H2 blockers, as well as prostaglandin analogs. And here's a list of your PPIs. These are your Zols, omeprazole, lansoprazole. Remember that Prevacid, that's what we're using to eradicate the individual of the H. pylori. Pantoprazole, which is the Protonix. You'll see that as an IV route for many times with NPO patients, as well as the esomeprazole, which is traded as Nexium. And this is just listing the H2 blockers. Talk to you a little bit more about antacids. We went over those a little earlier in the lecture, talking about the aluminum hydroxide and the magnesium hydroxide are the most commonly used preparations. They usually are not used alone. They do come in liquid and tablet form, and they are there to buffer the gastric acid and prevent formation of pepsin. You do want to use these or administer these cautiously in patients with renal impairment and heart failure patients because the antacids do have a high sodium content. So you want to avoid their use. Antacids buffer gastric acid and prevent the formation of pepsin. They're usually not used alone. Again, they're useful in treating small duodenal ulcers. The most commonly used preparations. Again, remember they are magnesium hydroxide and aluminum hydroxide. Make sure you're looking at those prototypes in your Davis drug guide in preparation for your not only your class exam but your boards as well. Antacids, for them to have their optimal effect, they should be administered 2 hours before meal and are effective 30 minutes to 3 hours after ingestion. And importantly, also, I'd like for you to please note that antacids are taken before eating, as if taken I'm sorry, I said that wrong. Antacids are taken after meals, not before. Before meals, it's taken before could cause a neutralizing. The neutralizing effect is diminished, so it will cause a change in its neutralizing effect. So your antacids are taken after. That's your AC and your AC and your PC. So your antacids taken after you have had your meals, and you have to arrange the administration of other drugs 1 to 2 hours from the antacids. Let me see, is there anything else I want to tell you about this? Oh, being cautious for those who have renal impairment because of their decreased capability to eliminate that magnesium and that aluminum. So it would be retained in your patient that is on dialysis and their kidneys are not filtering appropriately. And antacids are taken again after meals, but we administer them 1 or 2 hours before or after other medications because they can interact with those drugs. Some of you may have witnessed already in the acute care setting if your nurse had a patient that was on some type of antacid and noticing that there may have been a flag in, especially if you're at North Florida or the medical center, may have been a flag on that Meditech that said that other drugs had to be administered 1 to 2 hours before you gave that antacid, or excuse me, 1 to 2 hours after you gave that antacid. Mucosal barrier fortifiers are protectants. This is the sulforaphate. Sulforaphate is like Pepto-Bismol on steroids, I guess you can call it. It provides a protective coating that prevents further digestive action of both acid and pepsid. It does not inhibit acid secretion, but it does bind bile acids and pepsids to reduce injury. Sulforaphate may be utilized in conjunction with H2 blockers and antacids, but should not be given within 1 to 2 hours of an antacid. Sulforaphate should be administered on an empty stomach or 1 hour before meals and at bedtime. Constipation is the main side effect that is associated with its use. Prostaglandin analogs reduce gastric acid secretion and enhances the gastric mucosal resistance to tissue injury. They are effective in treating duodenal ulcers. Misoprostol, which is traded as Cytotec, helps prevent NSAID-induced ulcers and or high-dose corticosteroids. This drug should not be given to pregnant women as it does cause uterine contractions and could prompt premature birth or birth defects. This is unfortunately one of the drugs that they use in elective abortions because it causes the softening of the uterus and it initiates the uterine contractions. Oh, excuse me. The role of diet in the management of ulcer disease is controversial. There is no evidence that dietary restrictions reduce gastric acid secretions or that it promotes tissue healing. Although a bland diet does aid in relieving symptoms, food itself does neutralize gastric acid for about 30 to 60 minutes. Then there's an increase in the gastric acid secretion called rebound. Patients with PUD should be taught to avoid substances that increase gastric acid secretions. So what have you heard so far throughout this lecture and seen in your PowerPoint? Caffeine containing beverages. Yes or no? No, we don't want them. Coffee. Do we want it? No. These carbonated beverages and coffee, they have peptides that stimulate gastrin release. So coffee should be avoided as well as those caffeinated beverages. Non-irritating food should be consumed, especially during an acute phase. No bedtime snacks because food stimulates gastric acid secretions. And what position will that individual soon be in with sleeping? Supine. Remember, we can get them to lie on there right if need be. Small frequent meals are so much better than 3 large meals, and they may help. Although there is no evidence that state this practice. 8 in the ulcer hearing, no alcohol, no tobacco as well. So Table 5.5 lists some complementary and alternative therapy that may be or may offer some relief or improvement for those diagnosed as having peptic ulcer disease. Complications of peptic ulcers. Hemorrhage, perforation, pyloric obstruction, and intractable disease. Hemorrhage is the most serious of all these complications and leads and tends to occur more often with gastric ulcers and in older adults. With massive bleeding, the patient may vomit bright red or coffee ground blood. This is the hematogenesis. Timosis usually indicates bleeding at or above the duodenal junction. Minimal bleeding from ulcers is manifested by occult blood in dark tarry stools called melena. Melena is more common with duodenal ulcers. Blood loss from peptic ulcer disease does result in high mortality and morbidity. The individual with PUD should be educated to seek immediate medical attention if they experience sharp, sudden, persistent, or severe epigastric or abdominal pain, bloody or black stools, bloody vomitus or vomit that resembles coffee grounds, as that just indicates whole blood. The person who is actively bleeding has a life-threatening emergency. They need supportive therapy to prevent hypovolemic shock, which may lead to death. Hypovolemia is treated with fluid replacement with isotonic solution, such as normal saline and lactated gringers, which are started immediately. Serum electrolytes are obtained as they may become depleted from vomiting and nasogastric suctioning, so a metabolic panel is important in the continuity of care for these individuals. The HCP or healthcare provider may also order patent red blood cells to correct the deficiency or the low number in their hemoglobin or hematocrit. PUD complications. The first priority for care with an upper GI bleed is to maintain airway, breathing, and circulation. Remember your ABCs. O2 and other ventilatory support as the hemoglobin and the hematocrit are low. When you think of the hemoglobin transports oxygen. 2 large bore IVs for rapid fluid replacement and blood products may be ordered. Be careful with the elderly because of the risk for fluid overload, as well as those individuals that have some renal failure or heart failure. As nurses, we should monitor their vital signs or oxygen saturation and their hemoglobin and hematocrit. Perforation occurs when the ulcer becomes so deep that the entire thickness of the stomach or duodenum is worn away. The stomach or duodenal contents can then leak into the peritoneal cavity. Sudden sharp pain ensues that begins in the mid-epigastric region and spreads over the entire abdomen. The abdomen will be tender, rigid, and board-like. Remember this from your inflammatory bowel lecture. This is indicative of peritonitis. The patient can become severely ill within hours. Bacterial septicemia and hypovolemic shock are also soon to follow. Peristalsis decreases and paralytic ileus develops, and this is considered a surgical and life-threatening emergency. Perforation is managed by immediately replacing fluid, blood, and electrolytes, administering antibiotics, keeping that patient in PO. The patient should also be monitored for clinical manifestations of septic shock, such as fever, tachycardia, lethargy, anxiety, and or pain. Pyloric obstruction or blockage that occurs in a small percentage of patients is manifested by vomiting caused by stasis and gastric dilation.
Right.
Obstruction occurs as the pylorus is caused, obstruction occurs at the pylorus and is caused by scarring, edema, inflammation, or a combination of these. Managing upper GI bleed interventions, emergency management of hypovolemia by expanding intravascular volume while monitoring the fluid and electrolytes, obtaining a CBC, and coagulation studies are important. This is also listed in the critical rescue on page 1136 of your textbook. NGD can be done to assist in achieving hemostasis during the acute bleeding episode by isolating the bleeding site and providing a means of clotting. Acid suppressive agents are used to stabilize the clot by raising the pH level of the gastric contents. H2 blockers, PPIs, and antacids are also useful. Upper GI bleeding may require the insertion of an NG tube and a possible saline lavage. Interventional radiologic procedures such as a catheter-directed embolization or post-arteriogram care are also interventions that are used in managing upper GI bleeds. Especially for those who aren't surgical candidates. Post-arteriogram care would include assessment of the insertion site for signs and symptoms of infection or bleeding, whether it's femoral or brachial, as well as the assessment of the peripheral pulses. You would have that pre-assessment, and during your pre-procedural assessment of the peripheral pulses, and during your post-procedural care, you would be measuring these same peripheral pulses and then providing a comparison. And I already talked about perforation and pyloric obstruction. So surgical interventions are rare and are used in patients who do not respond to medical therapy or if an emergency develops as a result of any complication. Surgery includes that subtotal gastrectomy, which is partial removal of the stomach, a vagotomy, which is the clipping of the vagal nerve to control acid secretions, or lastly, a pyloroplasty, which opens the pylorus if there is a pyloric obstruction. And this is a pictorial of a total gastrectomy with, you see the anastomosis of the esophagus to the jejunum. Remember, anastomosis is the attachment, and the total gastrectomy is the principal surgical intervention for gastric cancers. So, gastrectomy surgery post-operative care. What do we have to be concerned about? Well, we want to monitor for the following post-op complications: dumping syndrome, alkaline reflux gastropathy, delayed gastric emptying, afferent loop syndrome, and if that individual has had a total resection of the stomach, we would also recognize post-op complications there as well. And give me just a second. It was something else that I wanted to. Table 55.3 in your textbook does list a diet for dumping syndrome. Dumping syndrome is a vasomotor response. It is the rapid emptying of food into the small intestines, and this causes a fluid shift into the gut, and that individual ends up with having some abdominal distension. Early manifestations typically occur within 30 minutes of eating. These individuals may have tachycardia, diaphoresis, palpitations, they want to lie down. These are clinical manifestations that should be reported to the surgeon, and the patient should be encouraged to lie down, and the patient at that point should be monitored for late symptoms. Those late symptoms can occur 90 minutes to 3 hours after eating, and the late symptoms are associated with an excessive amount of insulin. The insulin release follows a rapid rise in the blood glucose level that results from the rapid entry of high carbohydrates into the jejunum. Those individuals may present with dizziness, lightheadedness, palpitations, and confusion with the late signs of dumping syndrome. Nutritional management. Anytime that there is an issue with the absorption of the GI tract, it's that possibility that you're going to have deficiencies with your vitamin B12, folic acid, and your iron. You're going to have some macrocystic anemias to develop. The individual that has had gastrectomy surgery will also have impaired calcium and vitamin D metabolism, which is caused by the reduction of the intrinsic factor. You would want to monitor the CBC of these individuals for signs of megaloblastic anemia, which would indicate low red blood cells and low white blood cells. And how do we correct these deficiencies? Well, we supplement. We give vitamin B12 injections. Those individuals will also need folic acid, and ferrous sulfate is most oftentimes the iron preparation that is administered to individuals that have those deficiencies. And gastric cancer, These are malignant neoplasms or adenocarcinomas. They develop in the innermost lining and they often have zero symptoms in the early stages. The disease is usually advanced before it is detected, and because of this, the overall 5-year survival rate is very poor. There's a chart 55.6 on 1139 that distinguishes early versus advanced features of gastric cancer. Infection with the H. pylori is one of the largest risk factors for gastric cancer. And those individuals that have gastric polyps, chronic gastritis, high intake of nitrate foods, Barrett's esophagus. Remember, Barrett's esophagus or epithelium is pre-malignant, so they're more likely to develop gastric CA. The average age of development is 70, and it does occur more in males than in females. Health promotion, treating the H. pylori and the gastritis, encouraging the completion of therapy to ensure that the mucosa is healed, and the full elimination of the H. pylori will help. Even though you still have that increased incidence, it helps lower that increased incidence. Stress the need for these individuals to eat a well-balanced diet and limit the amounts of pickled food, salted, and processed foods. The most common early signs of gastric cancers are abdominal discomfort and indigestion. Most individuals change their diet, or either they utilize an antacid that eliminates the problem, and it's kind of like out of sight, out of mind. The tumor continues to grow. Then by the time that you have the signs and symptoms of advanced disease, such as progressive weight loss, nausea, vomiting, and obstructive symptoms, then you have to consider, has that tumor metastasized to the lymph nodes or to other abdominal organs, because think back again with that 5-year survival rate and how low it is. With advanced disease, you will see anemias. You'll have a decreased hemoglobin and hematocrit. So they may have some iron deficiency anemia. They'll, of course, have the macrocytic anemias, the vitamin B12 and the folate. They may have a positive OBFE, the occult blood fecal exam. If METS is present, it does like the liver, the pancreas, or the colon. So you may see an increase or an elevation in the liver and pancreatic enzymes. The CEA may also be drawn. The definitive diagnostic test used for gastric CA is an EGD with biopsy. CT, PET, and MRI scans are useful, but the gold standard is the EGD. Non-surgical management is based upon the severity of the disease. Radiation and chemotherapy are the most commonly used. Combination chemotherapy with cisplatin and epirubin are used before and after surgical removal of the tumor. Bone marrow suppression, nausea, and vomiting are the most common side effects of these drugs. Gastric cancers are sensitive to radiation. However, its use is limited due to the widespread disease amongst the abdominal organs, who can only endure a limited amount of radiation. Radiation may be useful as a palliative approach to care when surgery or cure isn't an option. Side effects of radiation do include impaired skin integrity, fatigue, anorexia, nausea, vomiting, and diarrhea. And radiation therapy can also increase the incidence of other cancers. Surgical management. Surgical management includes a resection and removal of the tumor. Primary surgical procedures include total and subtotal gastrectomies. Remember, MIS is a gold standard. You can do an MIS with early diagnosis and treatment, along with adjuvant chemotherapy and radiation, which may be curative for some, but for those that have mets to the lymph nodes, liver, or the parietal wall, it eliminates a cure via a resection. I'd also like to point out that palliative resections are only performed to increase the quality of life and to provide relief from pain, obstruction, or hemorrhage that the individual may be experiencing. Preoperative care, NG tube placement is done to rid the stomach of any secretions for a few days, and it may remain for a few days post-operatively to decrease the stomach as well. Enteral supplements may be ordered preoperatively to provide adequate nutrition and correct any deficits related to inadequate intake or deficiencies caused by the tumor. Intraoperative, the surgery removes a portion or all of the stomach. If the tumor is at the mid or distal portion of the stomach, then they do a subtotal or a partial gastrectomy, along with the removal of the omentum, which is the lining that covers the stomach and the abdominal organs. They'll remove the spleen as well as relevant lymph nodes. If the tumor is found at the proximal or the upper aspect, then that's when they do a total gastrectomy as well as the omentum and the lymph nodes. The surgeon then sutures the esophagus to the duodenum or the jejunum to reestablish continuity of the GI tract. Whipple is a radical procedure that may prolong the life of individuals. It does involve the removal of the spleen and the pancreas. However, the complications are serious and the complications are very common. With advanced disease, gastrectomies are performed only if gastric bleeding and or obstruction is present. Those with tumors at the gastric outlet who aren't candidates for subtotal or total gastrectomies may have palliative gastroenterostomies in which a passage is made between the body of the stomach and the small bowel, and it's usually the duodenum that is utilized. Post-operative care. Consider what you've learned in your perioperative lecture and throughout this course. We want to prevent the formation of atelectasis, paralytic ileus, wound infection, peritonitis, DVT formation. Think about your actions for prevention, auscultation of the lung sounds. Get that patient up and moving as quickly as possible, auscultating the bowel sounds, assessment of the wound. Are there signs and symptoms of infection, adequate incisional care, DVT prophylaxis, SCDs, the administration of heparin. Remember, NG tubes may the NG tubes are going to remain post-operatively to decompress the stomach, and you'll need to assess the patency of the tube every 4 hours in PRN or according to your facility's policy. Any decrease in patency may be caused by an obstruction of the tube, which could lead to some acute gastric dilation. Signs and symptoms of gastric dilation include epigastric pain, feelings of fullness, hiccups, tachycardia, and hypotension. Let's see, is there anything else I wanted to? Complications include dumping syndrome. I don't think I said it earlier, but one thing I want to say about dumping syndrome, those individuals should be encouraged to consume a high protein, high fat, low to moderate carbohydrate diet, but they do want to avoid concentrated sweets. Think about the late manifestations and what that late manifestation, what's the reasoning behind that? You know, you have that increase in the amount of secreted insulin. So for that reason, they want to avoid those concentrated sweets because it's going to cause a further increase. And in those severe cases, octreotide, which is traded as sandostatin, may be administered subcutaneously for dumping syndrome. So here I've just listed the early as well as the late manifestations for you. And then you have it there, high protein, high fat, low moderate carbohydrate intake, and avoid those concentrated sweets. And you have the sandostatin as well. And I referred to that table earlier in the lecture, that table 55.3, which is the diet for dumping syndrome. All right, this concludes your lecture.